and Global. And this is
I'm Christoph Correll. I'm professor of psychiatry and molecular medicine at the Zucker School of Medicine and also professor and chair of the Department of Child and Adolescent Psychiatry at Charité in Berlin. And I'm also the CMO of MedLink Global. We're really happy to be here in LA, unfortunately without you, but we're bringing you some goodies from the APA meeting in Los Angeles, where thousands of people are roaming around trying to find the right room and not being overcrowded to get some of the latest and the greatest. There wasn't only latest and greatest stuff, I have to say. I was a little, we had a hard time selecting too many sessions, but I think we got it to some goodies that might be helpful for you.
Sure. Christoph, how about we dive in? Tell me a little bit more about the GLP-1 receptor.
Yes, so basically, as you know, in medicine, there is a revolution going on for a couple of years now about GLP-1 receptor agonists. So those are glucagon-like peptide-1 receptor agonists. They are involved in insulin resistance and treat diabetes better than metformin or other treatments. But not only that, they actually reduce appetite. And there's now approval both in adults, but also in children and adolescents for weight loss. And not only weight loss in people who have diabetes, but just people who are obese. That has become a huge operation and also help for societies that are unfortunately getting heavier and heavier. And Novo Nordisk, that developed the first GLP-1 agonist that really went more than just daily injections, now weekly injection or oral, has changed the global product of money in Denmark because it's been used so much. There are other companies developing GLP-1 agonists, and it's all for medicine. But we are now realizing that it has to do with reward. And reward has also to do with substance use. So here, if you're reducing your desire to eat, or you don't have that need to satisfy yourself with food, what about substance use? So the session that we're bringing to you here was led by Ivan Montoya. He's at the NIDA in the National Institute of Drug Addiction and Alcohol Abuse. And Nora Volkov, the director of that institute, was the discussant. There were multiple presenters that you may or may not know, but the focus was, do we have potential for GLP-1 agonists to treat substance use disorders? And you know, it's so hard to compete with substances when you do psychotherapy or when you try to give naltrexone or naloxone. It doesn't really take away this desire, the craving. And the question is whether GLP-1 agonists could actually do that. And there are some open label studies that have suggested that, because the GLP-1 agonists also have to do with dopamine transmission in the brain reward pathways. They can cut down craving and drug use. And the current studies suggest that they may reduce alcohol consumption, opioid craving, nicotine, and cannabis use. Wouldn't it be great to have something that keeps you slim, but also keeps you healthy from a brain and life perspective by cutting down on substance use? So the questions that were raised during the discussion were, are there side effects? Because we've also seen some reports of maybe depression or suicidality when people dump their weight so much and don't have pleasure from eating. Is that something we need to monitor? It seems that some of these depression and suicide signals were more related to the underlying condition before and not necessarily related to GLP-1 agonists. But there was one particular question in the audience that I felt was really smart and interesting. So what if you start someone, for example, on an opioid analgesic, and they have a chance of becoming addicted to it? Mm-hmm. Should you pre-treat with a GLP-1 agonist to potentially reduce the chance and risk of having that condition? Or by extension, you could also do indicated or potentially also selective prevention by giving GLP-1 agonists low dose to people who have either a family history of substance use or have problematic substance use before it becomes an addiction. So I think stay tuned. This is something where medicine and psychiatry blend over, and this session really gave us a lot to think about.
And I heard about even in digital health, this is moving forward on the same addiction prevention and treatment topic.
Yeah, so NIDA, which is the psychiatric institution that actually has an agent that is responsible for the illness. It's the only one. In psychiatry, we don't know what's the reason, but here at least we know it's the condition of wanting the drug, taking the drug, that is the agent of disease in psychiatry. So they're very interested in using all methods that they can to improve outcomes. And obviously, AI and digital health can help prevent or treat addiction. So NIDA is very interested in and also putting out some grant proposal calls using digital health technologies like mobile devices, wearables, sensors, telehealth, and AI or machine learning tools, including software as medical device and risk assessment algorithms that can help us busy clinicians to advance addiction care. So the session that was brought by Susan Wright as the session chair, the moderator was Tam Nguyen, they actually looked at experts to discuss digital health challenges and promises in addiction prevention and treatment. And the problem with digital health, as we know, is everywhere that it looks great in studies when you pay people to do it. But then in the real world, what do people do?
Well, I think digital health has all kinds of components. I personally believe the phone app is the most challenging one for people to really feel sticky to it and study. As you said, when you pay people to do it, people will do it for money. But after the money is gone, it's very hard to have a new habit. And there are thousands and thousands phone apps available, and phone is so distracting. The moment you pick up your phone, you start doing something that you shouldn't not do.
And that's not related to the therapy.
Exactly, because you just forgot why you pick up your phone. You're supposed to go to that app, but you end up doing your Instagram right away. And this is so interesting that you combine all the parameters you can imagine: the wearables, right? The phone app, and even the AI tools to have the full picture to force that person to getting this addiction prevention. And I heard a while ago there's a very successful addiction prevention company. It's a digital health app that prevent people to use social media to treat that social media addiction. What they do is the moment, for example, you want to open your Instagram, they block your screen into focus moments and counting down 15, 14, 13 to make you have a deep breath. And once you have that time focus and decide, okay, this is not something I should do, let me close my app. Then you succeed, right, for this addiction, and then you accumulate scores for that. And the daily check-in as a reward for you to see the result of, oh, I haven't used social media for 1 day, 2 day, 3 day, 4 days. Then people realize, oh, that's great, that we're rewarding. So it become another addiction to accumulate that rewards, and people open that app, Instagram, to not using Instagram to to receive the reward. So that's another addiction. So you are beating one addiction to do another addiction. It didn't really work well, so the company also
Went under.
Eventually. Yeah.
But your examples point to one big problem. So first of all, you replace one addiction with the next. You're picking up your phone to do the app, but then you do your Instagram and other things. So reward is so powerful.
Correct.
How can we make AI tools, chatbots, other things so rewarding that people actually are drawn to it? And I think we don't have an answer to this yet. Therefore, we're still drawn to the bad habits that our AI or apps try to counter. Now, you mentioned something that having a 360, all of these tools together would be great. Actually, the call is more for like doing each of them as in isolation. But it would be great to have a 360. And I mean, Medlin Global is trying to do that actually, in order to have the tools blend together and have a digital clinic where everything is covered. And we'll talk more about this in future sessions. But another topic was?
lifestyle psychiatry prescription. I was so fascinated by that session. I never knew about it. I didn't know people can prescribe since like exercising or lifestyle related. I cannot imagine my doctor said drink 5 teas a day to me. And
Well,
I
I'll
don't
tell you to do that.
and how to monitor that, right?
Yeah. So there were many sessions on lifestyle, exercise, diet, and claiming even that changing your diet can treat disorders. So I think it's a little overblown, but making the term lifestyle psychiatry puts us on the spot. So we can't just look at symptoms, we can't just prescribe medications or do therapy for the brain, because the brain is connected through the neck to the body. And when there's obesity, when there are heart attacks and other physical disorders, that feeds back to the brain. People have more depression when they have physical health conditions. We know that inflammation is not a good thing. So putting us on the spot that a psychiatrist also needs to be a healthy lifestyle psychiatrist is, I think, helpful, especially with the pandemic of poor lifestyle behaviors in developed countries and even in developing countries. So in that sense, we should get to the habit of assessing lifestyle as part of our psychiatric care. And that's, I think, one aspect, because before you prescribe, you need to assess. And then we need to at least be educated a little bit about what diets are good or not, what healthy lifestyle websites might be helpful. So there's like something on glycemic index. There are many foods that have either higher or lower glycemic index. The higher the glycemic index, the more insulin is cranked out. Very like a spike. Insulin makes you want to eat more, so that's a bad thing. That's why diet soda actually doesn't prevent you from eating or gaining weight, because yes, the diet soda is 0 calories when you eat it or drink it, but then the next meal is higher because insulin is being cranked out. So there's a website, for example, www.glycemicindex.com, where you can see which foods are better for your pancreas and therefore also for your brain. Apropos brain, we now know because of GLP-1s that we talked about, the glucagon-like peptide 1 agonists, that the insulin resistance in the brain is also very relevant for multiple disorders. So here we may have a link to lifestyle. But lifestyle doesn't only include diet, it also includes exercise. And in that sense, we now know that exercise is not just good for the heart, it's also good for the brain. There are multiple studies that have shown that you can reduce negative symptoms, improve cognition, and treat depression. Very, very importantly, when you look at cognition, it's interesting that team sports actually have the highest effect size, because you're not only training your brain or airing your brain with aerobic exercise. By the way, it has to be aerobic exercise, but you're also interacting with people.
Yeah.
You have to look at them, try to figure out what do they
Human
want.
touch is important.
Yes, exactly. And that helps people function better. So there's one session that looked at, can you write a lifestyle, or how do you write a lifestyle prescription, was chaired by Ken Chris Hopper, and there were multiple presenters, including Doug Noxie, that some may know, that was really instructive in this regard. And then there were other sessions we mentioned that had similar content, but one had really a very provocative title.
Which is not prescribing exercise a malpractice?
Is that psychiatric malpractice? And I felt, I mean, the session, we didn't go to it, but from the abstract, it sounded like a repetition of many things. But I like the provocation there, because we need to really think also of omission, not just commission when we do something wrong, but what don't we do? And that was chaired by Jonathan Chavinsky, and the moderator was David Barron. And basically they said that there's a growing body of evidence that exercise is good for multiple things, but we are not using it well enough. There are also some CPT codes to talk to patients about healthy lifestyle, but obviously a lot of the actual activity, whether it's joining a gym or having a personal trainer, comes out of
pocket,
own
right?
pocket.
Or maybe you can use your HSA account, but still, it's your income is your own, pocket money.
And that disadvantages people with mental illness that often
Yeah.
don't have the resources. So, I
Yeah.
mean, it would be good that insurance companies reinforce or reward positive, healthy lifestyle behaviors.
Yeah. But Christoph, don't you feel it's so interesting that at APA that doctors are learning how to improving the lifestyle for my patient, how to even prescribing exercise for my patient, and then improving the dieting habit for the patient. But what did you eat this lunch?
I couldn't find anything at the meeting that was bearably or barely healthy. It was just all the US stuff. And I mean, I can't
Fried
believe it.
chicken
Fried chicken.
plus.
So it's really funny that we're on the one hand advocating lifestyle. We're not able to even do it at the meeting itself. So you have to order out or go outside. And LA has great restaurants, but that's real.
It's not easy. I couldn't
problem.
believe at the building we're staying, they offering doctor the least healthy food possible. Even the snacks what we got is butter popcorn all the time.
Yeah. Okay, let's move to the next one.
Sure. Let's talk about the novel mechanism of treating depression and psychosis. This is super medical, so I'll hand it to you.
Yes. So this was a session that covers some of the things we've talked about in prior MedLink Global presentations, including the psychedelics that I talked with Roger McIntyre about, and also the muscarinic agonist for psychosis that we discussed with Leslie Citrome and Jonathan Meyer. But this session was chaired by Steve Mater. He's actually at UCLA, so it was a home game for him. And he had as presenters John Crystal, who talked about the agents that have to do with NMDA and glutamate. That's one of his areas. And because John Crystal did early studies of ketamine in order to show that this induces actually similar symptoms as people have with schizophrenia. And then Steve Mater was talking about the agents, not in depression, but in schizophrenia. There were moderators. And what was discussed was, as many of you who've looked or watched our topics before, that there is a revolution that's bifurcated right now, ongoing in psychiatry. The one is in depression, that was basically triggered by ketamine, which is an IV anesthetic showing that it's helpful for depression, and that has to do with NMDA receptor antagonism, which then actually feeds into AMPA agonism and has a lot of increase in brain-derived neurotrophic factor. Now there's S-ketamine available as an intranasal treatment, and many other companies are going for the glutamatergic mechanism, either directly or indirectly using the NMDA receptor to have the treatment with the AMPA agonism, or now there are also AMPA modulators that are currently being tested. So this is wonderful. And since ketamine has been used as a drug of abuse and it's now being sanitized at low doses for the right people with depression, as you know, psychedelics have also raised their head, whether that's, for example, psilocybin, which is the farthest along, which is magic mushrooms, what's in there, and MDMA and LSD, other treatments are now unleashed from being basically buckled up because, oh my God, it makes the brain explode, it's bad for the brain, to no, if we use it in the right way with the right dose and the right setting, it might actually be helpful. Obviously, there was a lot of discussion in the session. How much do we need psychedelics to have that effect, the 5-HT2A blockade? Do we need the trip to really get somewhere, or can we get there without a trip? So the discussion is whether it's psychoneuroplastogens we need or neuroplastogens. And I personally see this as a stepping stone right now, using drugs of abuse that tell us about the brain and certain mechanisms, and then we sanitize it. We'll clean it up and have especially biased agonism below that receptor, or find other ways to actually have similar effects. So that was the neuroplasticity inflammation pathway for antidepressant treatment that John Crystal talked about. And then Steve Mater talked about what we've also discussed before, the muscarinic agonist. The only one currently approved is the M1, M4 xanomeline trospium, M1, M4 muscarinic agonist, paired with a peripherally restricted anticholinergic trospium, which has approval for schizophrenia. But there are multiple studies ongoing right now, including for bipolar mania. that's now in clinicaltrials.gov, but also for psychosis associated with Alzheimer's disease. And there will be multiple avenues for these muscarinic modulators. You know that there was a disappointment with the emraclidine, which is an M4 positive allosteric modulator, but I'm sure that will be repackaged and try to, again, be studied in schizophrenia. Then there was the neurocrine study with an M4 agonist that also was positive at 20 milligrams. So we will have multiple muscarinic agonists in the future. Other drugs that are innovative, TAR1 agonism, ulotaront, we may have talked about briefly at one of our sessions. That's a trace amine-associated receptor 1 agonist that was good in phase 2, but then didn't work in phase 3. Hopefully this will be also studied again in schizophrenia. It is currently being pursued because trace amine-associated receptor agonism has also an effect on dopamine, not only dopamine, but also on serotonin and noradrenaline. So it's currently being tested in augmentation of SSRIs in major depressive disorders and in generalized anxiety disorder. And then there are other innovative agents that are currently in phase 2 or moving into phase 3. One is LB102. That is the version of amisulpride, which has better brain penetrance. So it's a modification, a methylated amisulpride. Amisulpride, for those that are not in Europe or in other parts outside of the US, don't know this maybe. It's an older antipsychotic. It's a D2, D3 preferring agent that also has 5-HT2A, 5-HT7 antagonism. So it's good for depression and has been shown, and in some countries it's actually approved for dysthymia, but it's also been shown to be good for negative symptoms at low doses because of the D3 and 5-HT2A antagonism, 5-HT7 antagonism. And since it's now penetrating the blood-brain barrier so much and easier, what's been a problem peripherally with amisulpride, that's QTC prolongation and prolactin elevation at doses for psychosis that are like at 600, 800 milligrams are cut down because with the methylated form, it's only 50, 75, or 100 milligrams, and the effect sizes were very favorable. And then finally, there is another treatment that is tested at the moment for treatment refractory schizophrenia, where, as you know, we only have one agent available, that is clozapine. Since 50 years, we know this agent. It's called evenamide. It's in phase 3 now, or moving into phase 3, which is a selective voltage-gated sodium channel blocker. Why would sodium channels have anything to do with psychosis? Well, that has to do with glutamate release. And this evenamide selective voltage-gated sodium channel blocker only changes the balance of the glutamatergic drive when there's glutamate transmission increase and not at baseline levels. So that was an also very interesting session. Now, there were multiple sessions on AI.
Yeah. It's so funny that in this APA conference, we have so many talks, and the moment people hear AI, I see a crowd always. And at least 4 sessions I could remember more or less. The first is people talking about how they use artificial intelligence in transforming treatment for adolescent and young adult mental health disorders, provided by Dr. Hector Colon Rivera. And then...
And that's interesting because the young folks that are digital natives may be much more prone to using any of these kind of tools, correct?
Exactly. It has its own advantage by nature that adolescents, they're so easy to pick up the AI, and they're even feel more comfortable talking to an AI agent or chatbot compared to, well, unfortunately, their parents and and maybe a professional. Obviously, all this session, nobody knows the future of AI yet. All this session, we measure the balance between benefit versus harm. There are 2 specific sessions talking about AI beware. That is really risk assessing what can go wrong. And I think that's the main factor that prevents healthcare professionals to use AI on a day-to-day basis.
And
right?
what can go wrong?
I think the several big concerns, I think number one is data security. Where my data go? Where's my patient data go? Because all these AI new companies or solutions, if they're not integrated with EHR, people are concerning my data is actually going out from my patient profile. And where they go? What if you shut down one day? Where they are in the cloud? Yes, but where in the cloud people have
To
no
have still
idea,
access,
right?
and is it safe? Yeah.
Yeah, and the second is, what if AI tell patients to do something? Because for mental health patients, they're very vulnerable at baseline, and they're very easy to, especially young adults, over trust certain AI characters. There were bad event happened before already, to over trusting, thinking that's professional service, which is not at all, and then did things that, unfortunately very risky. And the third piece will be the concern about how to integrate into the workflow. People have seen the power of AI already, but how to really seamlessly and affordably integrate the current workflow. Because, for example, the nose generating AI tools are very popular right now, but doctors are paying for it, right? You're really moving part of your income to pay that, which we believe will soon be more affordable, or even for free.
And so we're at MedLink Global are addressing exactly that last point, how to integrate AI and also being still human into the workflow. And we'll talk more about this. But there was also the question, how do you integrate AI into training of young residents? Because they are the future and they need to know about these tools, correct?
Exactly. There's one session called PGY AI, the impact of artificial intelligence on psychiatry education, by Dr. Eric Kramer. And then we have seen different programs are trying to integrate with AI into training. But again, the unclear policy of using AI is kind of preventing people from adopting it in a larger organization. And the next session I remember is called Clinical Updates on Large Language Model and Artificial Intelligence, by the well-known John Toros. And that's, I think, more general. And people also assess the benefit and potential harm from
Absolutely.
adopting AI.
But you wanted to talk about one in particular, correct? And that is the role of AI chatbots in mental health. So what's that about?
Yeah, that one specifically interests me because I use social media all the time, and I always.
I don't.
Well, yes, that's good for you. I should learn from you. The chatbot usually in social media is as a customer service, or as a guidance. What do you need? How can I help? Right. But today the landscape has been changing completely. The chatbot become more like a companion, like a team member, like a even partner. And then
or therapist,
exactly, or therapist, friends, right? And then that push people to not push people, naturally people start sharing more things with the chatbot than ever. So how can we leverage that in mental health treatment or even diagnosis, right? Because the true self is showing in social media. We can definitely use that information to do more, but obviously the risk come also, as I mentioned before. If the chatbot starts telling people to do certain things in the social media that you use on a daily basis, it can be concerning.
Yeah, so there are multiple pros and cons of chatbot use. Maybe you can summarize some for the audience, and then we'll wrap it up afterwards.
Definitely. So number one, they're always there 24/7, unlike your friends and therapists. You can talk anytime when you're feeling not good or feeling very good. The second is definitely non-judgmental, low cost. You don't need to pay extra for anything, and you will feel it's personalized because it's your account. They know everything about you. And I would say, with all this information people share in a very narrative and detailed, qualitative way, It's also possible for early risk detection. What if I said something to my chatbot that, I'm feeling really sad, or I have suicidal ideation, and then it's really good for the platform to identify and intervene.
But what are the cons?
There will be AI just being AI. People feel it's natural language, which is true, but AI has zero empathy. I don't want people to have fantasy about AI is my friend.
But maybe they need to have the fantasy, and then it becomes empathetic, because sometimes, ChatGPT tells me things, and I have a feeling that ChatGPT wants to be friendly, and it's all what we project. That's when you fall in love also, you project on people, and we can project on AI and make it our team member to the better.
Absolutely.
But it doesn't have the true empathy. So it's not a real person. We shouldn't replace this with real relationships. It might be an extension, but not a replacement.
Yes, they're mimicking empathy, which is working, and people feel good about it. That's why people talk to AI more and more. But the actual human touch is never replaceable. The second is false assurance that people really need help, and they assume my chatbot has all the professional knowledge, they can help me, just like my therapy, which is not true at all.
So they don't know what they're lacking, and they may go too late now to a psychiatrist or psychotherapist. We think it bridges the gap, but it might actually extend the gap.
Yeah, it can cause delay. And the privacy risk is obviously there. And also bias, because every model are trained by a group of talent, and it reflects what they absorb. So whoever are using this model, they might be the same group of people, like all the teenage group of people using this, and then you talk to them, but actually it's really within that little bubble, and it's super biased.
Yeah. Okay, well, that was quite interesting. I think that wraps it up.
Yeah.
We hope that this was helpful to you who couldn't be here at the APA, or even if you were, you can't go to all sessions. You might actually have not always been inside of the conference center. But this was our selection, and we look forward to seeing you also next month for another session. Hope that this was helpful.
Yeah, we'll keep you updated at our channel, at the LinkedIn and other social media channels. Thank you. Have a rest of your day.